Welcome back. I want to take a moment to remind you that the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA-ASA. The AHA-ASA does not endorse any product or device. It is my pleasure to welcome our first speaker, Dr. Isaac Bourgeois. Dr. Bourgeois is a neurointensivist at Advocate Health since 2022. He earned his medical degree from the University of Illinois, completed a neurology residency at Northwestern University, and a neurocritical care fellowship at the Feinberg School of Medicine. Please note that all full speaker biographies will be available in the lobby of the Zoom events platform. Dr. Bourgeois, the floor is yours.
Thank you very much. I'll get my screen pulled up here. Let's see. It's not letting me share my screen right now.
Okay. Let me, one moment.
You should be able to share now.
Got it. Okay. Well, I'm very pleased to be invited to kick off our summit today. I'm going to be talking about spontaneous intracerebral hemorrhage, pathophysiology, and medical management. I have no disclosures. We're here, of course, because spontaneous intracerebral hemorrhage represents a highly mortal and morbid form of stroke. It represents a minority of our total stroke cases. You can see about 80,000 cases in the United States per year, but the mortality of this intracerebral hemorrhage is twice that of ischemic stroke. When we talk about the causes of ischemic stroke, or rather of hemorrhagic stroke, we divide these into location. And so in terms of deep intracerebral hemorrhages, we're thinking about primarily hypertensive angiopathy causing hemorrhages in the basal ganglia and in the cerebellum. And in lobar locations, we can have hypertensive angiopathy as the etiology, but also cerebral amyloid angiopathy. There are, of course, many other conditions that can cause hemorrhage in these locations, but they're really separate diseases in their own right. I'm thinking of vascular malformations, metastases, other processes like this. We often extrapolate the management of the hematomas in these conditions from the management of a spontaneous intracerebral hemorrhage, but really we're talking about hypertension and cerebral amyloid angiopathy when we talk about spontaneous intracerebral hemorrhage on its own. And then cerebellar hemorrhage can draw from either etiology, can be hypertensive, can be cerebral amyloid, or other etiologies, kind of a grab bag. Hypertensive angiopathy, of course, is a result of exposure to chronic hypertension. This results in lipohydrosis of small arterioles. And we used to think this resulted in the formation of what were called Charcot-Bouchard aneurysms or microaneurysms you see depicted here in the H&E stain image. We now know that mostly this is simply medial degeneration of very small arterioles like you see depicted here, usually at a bifurcation. These are tiny, tiny arterioles, usually deep in the brain, that are a few hundred microns wide, that have the walls of these arteries degenerated and then lead to rupture. You can see the blood erupting here on this electron micrograph. Cerebral amyloid angiopathy, in contrast, is also a small vessel angiopathy, but in this case caused by the accumulation of pathologic A-beta protein. So this is the same A-beta that accumulates in Alzheimer's disease, whereas in that condition, it accumulates inside neurons. In cerebral amyloid angiopathy, the A-beta leaves neurons and accumulates around blood vessels, resulting in sort of this double-barreled appearance you see depicted here on A-beta immunohistochemistry that results in friability and increased susceptibility to rupture. That can lead to the classic clinical presentations we're familiar with, which is primarily lobar macrohematoma when we see it. But then also on MRI, we can see evidence of this condition in the form of cortical microbleeds. These represent small bleeding events from tiny extravasations of cortical arterioles that evident on susceptibility-weighted imaging. When the arterioles affected are in the subpial space, you can see actually convexity subarachnoid, what looks like convexity subarachnoid hemorrhage, here seen on susceptibility MRI, that we call superficial siderosis. And this is associated with a very high risk of recurrent intracerebral hemorrhage. Now, the pathophysiology, the way intracerebral hemorrhage evolves in the brain, is a process that comprises acute hematoma dynamics that we'll talk more about, can really evolve to become a multi-system condition throughout the critical care course of these patients, and then continues on into the long-term recovery and secondary prevention phases of care. There is no way in 20 minutes I'm going to be able to talk about all of this. So I do want to highlight right now the 2022 AHA-ASA guidelines that really go through in a comprehensive way all the dimensions of care, from medical and surgical management to the general management of medical complications and recovery following these onset of intracerebral hemorrhage. I also want to highlight that I'm going to be referencing the class of recommendations provided in the guidelines here using this color coding scheme as I go through my talk. I'll also take just a moment to highlight this excellent resource from the AHA. This is a PowerPoint that is available on the website. You can also Google it. It'll be one of the top results you see that provides really nice summary slides for those of you involved in the education of staff in your units and in your departments about workflows for imaging evaluation, for example, or a nice flow sheet for the appropriate anticoagulant reversal agents to use, and on through recovery and secondary prevention guidelines. So a really excellent resource I want to highlight. I'll pull some figures from this in my talk today. Today, I do want to focus on some of the acute hematoma dynamics and how we think about managing those medically. And I'm also going to touch on prognosis and how that affects the way we think about the care of these patients. So the pathophysiology of intracerebral hemorrhage is characterized by the primary injury and then evolving secondary injuries in the brain. The primary injury is, of course, what we talked about already, the arteriolar rupture, which leads to extravasation of blood products and local macrostructural distortion, displacement of the brain that can result in axonal and microvascular shearing. There really is no medical management of that primary process. The medical management is prevention, either primary or secondary prevention, control of blood pressure, avoidance of anticoagulants in folks with predisposing conditions. The secondary processes are targets for intervention. So perihematomal edema and inflammation is the reaction of the brain to that macrostructural distortion, shearing of axons, and also the inflammation caused by the presence of blood in the brain. In terms of medical management for this, we've tried a couple of things. We have clinical trials looking at targeting this as a therapeutic intervention, and we have not yet shown any benefit of medical therapy. It's possible that this may be one of the major targets whereby surgery can benefit these patients. And there's more to come. Dr. Chen will be talking about that in his session. Intracerebral hemorrhage can result in substantial mass effects, compression of adjacent brain structures, and secondary brain injury, and of course, global intracranial hypertension. Medically, osmotherapy has some role in this, can be helpful for transiently lowering intracranial pressure, but we can rapidly exceed the limits of what osmotherapy is able to do, and surgery remains really the major, most potent intervention when it comes to these problems in these patients. Of course, when there is a periventricular focus of hemorrhage, and the hemorrhage can erupt into the ventricular system, causing IVH and hydrocephalus. IVH, even without hydrocephalus, we know is associated independently with worse outcomes. I wish we had a medical intervention for this. We don't. This really remains, again, a surgical problem where we need drainage. Often we need external ventricular drainage and sometimes thrombolytics to help clearance of intraventricular hemorrhage. And so the medical management of acute hematoma rupture is really focused not on any of these secondary processes. It's focused on the early evolution of the hematoma that can potentiate and exacerbate all of these structural complications. And that we call that hematoma expansion, or the enlargement of the early hematoma after onset. Hematoma expansion is an independent predictor of poor outcome. A single milliliter increase in hematoma volume is associated with a 5% increase of odds in death and disability. It occurs in about a quarter of intracerebral hemorrhage patients. We know that it occurs early. If you look at this chart over here, you see there's a time decay in the probability of seeing hematoma expansion in our patients. From early, by 3 hours, that the likelihood of seeing this is cut almost in half, and it decays the further out we get. And so this underscores the importance of early response times following onset of stroke symptoms to identify, of course, if this is ischemic or hemorrhagic. But with hemorrhagic stroke patients, the time is of the essence, just in the same way it is with ischemic stroke patients. We have an early window where folks are likely to expand their hematomas, after which the interventions that we use aimed at preventing hematoma expansion are no longer relevant because it's unlikely to continue bleeding. So as I said, associated factors here, earlier time to baseline imaging, just catching it earlier means we're more likely to see it. Higher baseline ICH volume is associated with increased risk for hematoma expansion. That's probably because of the structural distortion that leads to greater shearing of small vessels near the hematoma that can lead to further hemorrhage. Uncontrolled hypertension and antithrombotic medication use for intuitive reasons both contribute to hematoma expansion. And then the CTA spot sign, along with some other radiographic markers, are also predictors of hematoma expansion. And this is our opportunity to intervene medically. The idea being, as summarized by one of my mentors, is to keep small hematomas small. So these are our targets for intervention, and these are time-sensitive targets, are blood pressure management and reversal of coagulopathy. I've listed here as well administration of hemostatic agents. There's been investigation of using hemostatic agents in patients that are not coagulopathic, recombinant factor 7A, tranexamic acid. These have not yet shown benefit. There may be a time where we begin to use those, but not yet. In terms of blood pressure management to prevent hematoma expansion, 2022 guidelines recommend blood pressure control that is targeted, so targeting a systolic blood pressure goal of 140 with a range between 130 and 150. That's timely. We want to do this as early as possible, and that is smooth, avoiding large variability in blood pressure. And these recommendations are really built on the results of these two clinical trials that were published about a decade ago each. Interact-2 and Attach-2. And they were very similar trials in some ways. They both had less aggressive and more aggressive blood pressure control targets. They're also both similar in the fact that their headline outcome was negative. These were trials that did not show a difference in their major outcome, which was just good outcome versus bad outcome. But there were some things we still learned from these trials. First of all, when we combine the data from both of these trials and look at this, we see that there's clearly a trend towards higher blood pressures being associated with greater risk for hematoma expansion and lower blood pressures having less likelihood of hematoma expansion. So the biological concept or theory seems to be borne out by this evidence. We also see that that's associated with an outcome. As we know, hematoma expansion is associated with worse outcomes, and the higher blood pressures were in this group, the lower likelihood of functional recovery, lower blood pressures being associated with better recovery. And so on the basis of that finding and on the basis of a secondary endpoint, which was sort of what's called ordinal shift analysis, this is looking in a more granular way at the sort of categories of disability and not just saying a dichotomized good versus bad outcome. There was a benefit of this intensive blood pressure control in the Interact-2 trial. And so the recommendation we get from the guidelines here is to target a blood pressure of 140, which is what they did in this trial, and targeting it between 130 and 150. Now, that 130 floor doesn't come from this trial, really. It shows us that the performance of blood pressure control right around 140 was associated with improving outcomes. We get that floor setting of 130 from the results of Attach-2. Now, Attach-2, like I said, similar trial in some ways. One major difference is you can see here is the standard treatment arm they had, which actually looks like they controlled blood pressure about the way the intervention did, the red line here in Interact-2, versus their more aggressive treatment arm, which was lowered blood pressure much below 130. So Attach-2, like I said, another negative trial, they did not show any beneficial outcome. But what they did see, compared with Interact-2, was that they saw that there were more adverse events. And so specifically the renal adverse events, and that's probably because of hypoperfusion of the kidneys in patients with chronic hypertension is the thought. And so that leads to the class 3 recommendation or the suggestion of harm for saying for patients presenting with blood pressure over 150, we should avoid over-aggressive lowering to less than 130 because that may be, in fact, harmful. Now, the next thing I said about blood pressure control is that it should be timely. This is an analysis of many studies, pooled data from many studies, over 5,000 patients, showing a clear linear relationship between time to blood pressure control and increasing odds of poor functional outcome. So the faster we control blood pressure to target, the better the odds of a good outcome, or in other words, the lower the odds of a poor outcome. So we want to initiate it as soon as possible and achieve our blood pressure target within 1 hour of treating. Lastly, we want smooth blood pressure control. These are data from Interact-2 and Attach-2 as well, showing that the greater variability in blood pressure was associated with increased odds of mortality and increased odds of neurological deterioration. And so we want blood pressure control that is continuous and smooth and avoids wide variation, either high or low, to avoid patient harm. Okay, so that's the recommendation for blood pressure management. There are some open questions here that we don't have good answers for. We don't know what to do with patients presenting with very severe ICH, low GCS, because those weren't included in these trials. We don't know the optimal blood pressure strategy for patients that are going to be undergoing surgery. And in this new era of surgical interventions we're talking about today, I think that'll be the subject of ongoing research to figure out how to manage these patients optimally. We also don't know what to do with patients presenting with extreme hypertension. The INTERACT-2 included patients with blood pressures only up to 220. And so when we get above that that's termed in the literature extreme hypertension, we're not sure if we should be lowering them as aggressively or if we should be a little bit less aggressive to avoid exacerbating perhaps renal hypoperfusion, cerebral hypoperfusion in those patients. Those are open questions. The second pillar of preventing hematoma expansion medically is addressing coagulopathy. Fortunately for anticoagulation, we have a wide armamentarium of specific reversal agents that we can use depending on the oral or intravenous anticoagulant in play. And I won't go through these in detail, but it's important to make sure your institution has available these pharmacotherapeutics because they have a good evidence base and the AHA recommendation behind them to be used in the context of acute intracerebral hemorrhage to target hematoma expansion. Unfortunately, when it comes to antiplatelet agents, in 2025, we do not yet have effective reversal agents for antiplatelets. There was a reasonable hypothesis that perhaps platelet transfusion might reverse the effect of platelets that have been antagonized by aspirin. Prior trial, the PATCH trial, tested this hypothesis and showed that patients receiving platelet transfusion to reverse the effect of aspirin actually had worse outcomes, higher odds of death or dependence at 3 months. And so we recommended against using platelet transfusion in these patients. For patients undergoing surgery, there's an idea desmopressin increases the activity of von Willebrand factor, factor VIII, and biochemically it reverses the effect of aspirin in assay. It doesn't seem to do so in clinical trials, doesn't seem to affect hematoma expansion or functional outcomes. For patients undergoing surgery, there is one trial a little bit over a decade ago published, it's moderate quality, that showed that there were improved outcomes in platelet transfusion for patients undergoing surgical intervention. There were some limits with this trial. They didn't report their serious adverse events. They excluded patients that had incomplete hemostasis in the OR. So when I look at that trial, it makes me think that platelet transfusion works for patients going under surgery all the times, except for the times that it doesn't, is what that trial looks like to me. But that is something that is considered reasonable by the guidelines. But this remains an area where we have urgent need and we need to figure out a way to address the coagulopathy caused by antiplatelet agents. And we don't yet have a good management for that. Since the publication of the guidelines in 2022, we have 2 more clinical trials supporting these recommendations and showing benefit to the interventions that we provide. The first of these was INTERACT-3, published in 2023, one of the biggest ICH trials ever. And this looked at not just reversing coagulopathy, not just treating blood pressure, but a bundle of care, including those elements, as well as managing fever, controlling glucose. And it showed that there was an improvement in the odds of good outcome at 90 days. Interestingly, only 1% of the patients in this trial were on anticoagulation. So the effect was probably driven mainly by blood pressure control and then general medical management, aggressive medical management. INTERACT-4, published the following year. This was a trial of aggressive early blood pressure lowering in all patients presenting with a stroke syndrome pre-hospital. And so this, obviously at this point, they were not differentiated between ischemic and hemorrhagic stroke patients. This was a negative trial in that overall it didn't improve outcomes, but for the subset of patients with intracerebral hemorrhage, there actually was a significant improvement in functional outcome. And this underscores the idea that blood pressure control is a viable target to reduce the odds of hematoma expansion before we get to those other secondary injury mechanisms that I talked about earlier. Now, the next thing I want to talk about today is prognosis and decision-making in intracerebral hemorrhage in the last minutes that I have. I want to talk about this because I think it actually has a bigger impact than any of the things that I've just talked about in terms of medical management. The guidelines, as we all know, recommend that we use a baseline severity score when we're admitting patients with intracerebral hemorrhage. It says that it's reasonable to use this as a framework for having conversation with caregivers and decision makers, but that we shouldn't use it as a sole basis for forecasting how patients are going to do. And I want to talk about that for a minute. We all know the ICH score. That's the main tool people use for assessing severity of intracerebral hemorrhage. This was a score that was developed now a quarter of a century ago. Dr. Claude Hemphill was the leader of this effort. And it was really designed to be a severity scale that anyone could use. You didn't need special neurologic training to be able to judge these contributors to severity and and help predict severity of intracerebral hemorrhage, to standardize the language with which we talked about these patients. For better or for worse, and I think for worse, one of the things that was been focused on tremendously from this paper was the mortality data that was included. Now, I've talked to Dr. Hempel about this before in person, but if you can't do that, I recommend reading his editorial that he wrote in 2018, where he talks about this process, how when this data was derived, they were doing this to simply show that the score graded patients was associated with increasing severity, but the mortality data they used, the population they were coming from, was a population where patients were not being offered aggressive management of intracerebral hemorrhage. And the management of these patients has really evolved over the last 2 decades, and yet we still cite this data regarding mortality. And what this has led to, and what many people in the field, myself included, are trying to fight against, is the idea of self-fulfilling prophecy. The idea that we see an ICH score, we see the associated mortality based on very old data, and that influences our thoughts and beliefs about how these patients are going to do. And that changes our attitude as we talk to decision makers and caregivers about how these folks are going to do. And that influences our actions and their actions. And that can change ICH outcomes. And one of the major ways that this influences our actions is through early care limitations, seeing these patients, believing that they won't do well, and then deciding to not provide aggressive care. And so this has been known to be a problem for a long time, and many folks have looked into this. One of these efforts that I want to highlight is led by Dr. Morgenstern and published in 2015. This was a trial that across 5 U.S. hospitals, where they weren't offering any specific ICH intervention as part of the trial. The only condition of the trial was that there was no withdrawal of life-sustaining therapy for the first 5 days. In the first 5 days, patients received full aggressive care for intracerebral hemorrhage. After that, there was no prescription against withdrawal of life-sustaining therapies or whatever the wishes of caregivers may be. And what they saw was, by simply not giving up in those early days, there was a dramatic reduction in mortality, much greater magnitude of effect than anything I showed you in terms of reversing anticoagulants or blood pressure control. You can see here, this is the data from the original paper. Here, that's repeated in this darker green bar. And then the gray bar shows the mortality they observed by simply not withdrawing care in the first 5 days. Again, decision makers, patients were free to make decisions about anything beyond the first 5 days. But when they provided early care, mortality dropped dramatically. This was taken a bit further in a subsequent publication where they got a bit more granular. They observed a cohort of patients, and there were no prescriptions against early care limitations. They simply observed what were the outcomes of folks with early care limitations versus those who were treated maximally. And again, you can see in the dark green here, you see the typical ICH score data that's cited. The light green shows the mortality for their entire cohort here. So this is even including early care limitations. They saw better mortality now almost 20 years after the publication of the ICH score data. But then the patients who were treated maximally, received full interventions, much better mortality outcomes. And they use propensity score matching to say, let's look at the folks in the group who had early care limitations, withdrawal of life-sustaining therapies, and folks who received maximal care. Can we match them and predict how some of those patients might have done? And that's an imperfect method, but doing that, their evidence suggested that about half of the folks that had early care limitations may have survived, and almost half of those may have actually had a good outcome. And so they use this data to create a more refined prediction scale called the max ICH score. It's not much more complicated than a typical ICH score, but it does use a little bit more granularity. Instead of using GCS, it uses the NIH in more categories, age into more categories. It separates lobar and non-lobar ICH in the presence of anticoagulation, in addition to the typical factors associated with the ICH score. And you can see that it gives you not just mortality prediction, but it gives you a bit more granular breakdown as to the odds of various levels of disability based on this scoring. And so I encourage you in your patients to reference more updated data when you're thinking about the risk of mortality, and to remember that a lot of that mortality, probably half of the mortality in that original paper, was attributed simply to early withdrawal of care, and that we live in a different era in which we can provide more aggressive and more effective care for these patients. I think I'm close to my time. I'll just briefly comment that we want to avoid The guidelines say that we should avoid making new DNR orders or withdrawal of care until the second full day of hospitalization, just to provide at least the first 24, 48 hours for the dust to settle for our patients. And they also remind us that for folks who have a pre-existing DNR status, to remember that that applies to a code situation only and should not result in limitation of care in any other domain. We should still be providing full aggressive management. Now, lastly, at the end of my time here, I want to just leave you with this data. This is data from two clinical trials, two surgical trials that you'll hear more about in subsequent sessions today. These are both headline, again, negative trials in their headline. Their primary outcomes didn't show benefit. But the reason I want to show them is that they followed the patients in this trial out to 6 months and a year to show how these patients do. Because I've just talked to you about how we can reduce mortality in ICH, but I haven't said anything about improving functional outcomes in those patients. This is data that they looked at for patients in their trials who had poor functional outcome, MRS of 4 and 5 at 30 days. So 1 month into their ICH course, these are folks that were still completely dependent, many of them breathing tube, feeding tube, long-term care setting bound, after 4 weeks. And by 6 months, some of those patients, you can see that that's representing these orange bars here. By 6 months and a year, some of these patients had died in the orange. Some of these patients were still quite disabled. But a substantial portion of these patients in both trials had significant improvements in their functional outcomes, to being more awake, to being more interactive, some of them to becoming ambulatory, some of them to being almost symptom-free, and some of them, a minority, a very small number I'll allow, but a very small number of them even returning to baseline neurological functioning. And so even in our most severely affected patients, there is every reason to be aggressive, to believe in the resilience of our brain and the capacity for recovery of our brain, and to avoid that self-fulfilling prophecy of believing that these are patients that will simply do poorly. So I won't review my conclusions right now. I'll stop there because I believe I'm over time and take any questions and make sure we can move forward with our other speakers.
Thank you so much, Dr. Bourgeois. That was fantastic. And I know we gave you quite the hefty agenda in a short amount of time. So I know our attendees were educated on many topics. So we did have a couple questions that were looking at the reduction in mortality correlated with functional outcome and quality of life, which I think you just addressed very nicely in that last slide. What is the best quality of life scale that there is to use in ICH? Has there been one that has been adopted?
Yeah, that's a great question. So in most clinical trials, the scale that's used is called the modified Rankin scale. There are some criticisms of the modified Rankin scale. There are, of course, other outcome scales that are used. I don't have the data to show you here, but from this same cohort of these trials, actually, I believe it was from MISTI 3. There is, I believe, unpublished data, but data that I've seen presented regarding not just this is a neurologic functional scale, meaning it's graded by somebody like me examining a patient and making an assessment. They have data. There are lots of standardized quality of life scales, and actually tools like in the NIH Toolbox, for example, that can look at patient-centered outcomes and their preferences and beliefs about their care. And I'm citing unpublished data here, but this is from Johns Hopkins. The upshot of that data was that when you survey patients and their caregivers who receive this aggressive care through a year, their quality of life scale ratings, and these are again coming from the NIH standardized scales called their quality of life ratings, are similar to that of the general U.S. population. And when you ask these patients if they were happy to have received this care, the answer is overwhelming. The overwhelming majority is absolutely yes. And so it's an excellent question. I apologize, I don't have that data to show you right now. But it is important also to highlight these are scales produced by somebody looking at the patient, but we should be thinking as well about the experience of the patients. And I think that's been a major thrust in NINDS and the NIH in terms of focusing on not just how patients do functionally, but how they feel about how they're doing. So that's a great question. I appreciate you highlighting that.
Absolutely. Thank you. I appreciate our audience. We do have one real quick question. Who in your mind should be the primary person to be documenting the initial ICH score?
That's a good question. At the institutions where I work, it is shared. We all try to document it. The neurosurgical side and the neurointensive care side, we all try to document it separately. I think that is who is the best person to do it. I think anybody who is able to, the hardest part of it is getting a hematoma volume. And so it depends on the workflow at your institution. If your radiologists are providing a standardized hematoma volume, then anyone should be able to document it because the other factors are readily extracted from the medical record. Often it falls to neurosurgery and neurointensive care as being the ones who are familiar with using a score like an ABCD2 score to calculate hematoma volume based on a CT. I think anybody who has adequate competence at that would be appropriate. In my opinion, I think the neurointensivists are very well positioned to do that. But that'll depend on sort of local resources and expertise, I think.
No, thank you. We understand sometimes the difficulty in operationalizing that documentation. So we appreciate your feedback from your model share at your organization. So that does bring us to the end of our time. Thank you, Dr. Bourgeois, very much for your presentation. And as a reminder, his slide deck can be found in the resource tab of your screen. We will leave this session now, and if you'd like to click on the resource tab to join our session 2, we will be moving over there and I'll meet you in session 2. Thank you.